Hi, my name is Dr. Arslan Kahloon. I'm an associate professor of medicine at Arlington Health System in Chattanooga, and also program director for GI Fellowship at University of Tennessee College of Medicine in Chattanooga. Today, we're going to be talking about updates in GI. So let's begin with that. So the brief agenda that we have for today's talk is we're going to quickly talk about colon cancer screening and what's new about that. We will talk about various options that are out there. We will also look into some of the new recommendations and guidelines related to a new starting age in terms of screening for colon cancer screening. Also, we'll touch briefly upon some of the new technologies that are out there in colon cancer screening. And then we'll touch upon another topic, which would be fatty liver, which a lot of people have heard of or are aware, and also a term called NASH, which is non-alcoholic steatohepatitis. We'll briefly talk about some definitions and clear up some concepts, talk about how things need to be worked up and some options for treatment in terms of fatty liver and NASH. Now, the third portion of our talk would focus on GERD, which is acid reflux or gastroesophageal reflux disease. And we'll talk about some of the basic workup treatment options and what newer treatment options are out there as therapy for GERD. So let's dive into this. I have a disclosure about Magentic Eye that I'm part of, and we would not talk too much about what this is related to. However, there would be portions of this talk which would incorporate technologies which are being used as part of this disclosure. So talking about colorectal cancer, I'm sure most of the people are aware of the recent death of famous Black Panther actor Chadwick Boseman, who died of colon cancer last year, and that reignited the debate about colon cancer and early colon cancer, and also reignited talk about racial disparities in terms of screening. And that's why I think it was important to sort of refocus on some of these issues and talk about that in detail. So unfortunately, Chadwick Boseman died at age 43, which is a very young age, with colon cancer, which is a totally preventable cancer by colon cancer screening options that we currently have available. And as I was alluding to earlier, his death has highlighted the rising incidence of colon cancer among younger people, and also reinvigorated the discussion regarding racial disparities in screening and then the death rates in certain ethnic populations. So if you look at these two graphs that help us talk about, what we were going to dive into next. Colon cancer is the second most common cause of death in the United States. And the sad part is it's a cancer that is very preventable through screening and surveillance procedures. And there has been about a 30% reduction in the overall incidence of colon cancer between 2003 and in 2012. And that's partly attributed to results of increased screenings that we've been performing and overall improved health behaviors in our population, especially smoking reduction. Since 1995, we have successfully helped reduce the incidence of colon cancer by increasing our screening performance in our disease population. And if you can see in this graph, starting in 1975 up until the mid-2010s, the overall incidence of colon cancer in both men and women actually had declined over time. However, the problem that we're noticing now is that if you look at a subgroup of this population that is getting exams or colon cancer, this is the worrisome part. In younger adults between 20 to 49, our incidence of colon cancer is actually starting to go up overall. And similarly, the mortality in this group, which is the younger group, has started to initially plateau and then started to creep up now. And this trend in younger population is in contrast to older age groups, in which we were able to successfully decrease colon cancer incidence and also death related to colon cancer. So we were successfully, by implementing screening and surveillance protocols, were able to reduce colon cancer incidence by 1%, 1% per year in individual between the age groups of 50 to 64, and 3% in patients who are above 65 and older. So again, something which talks about the same concept. this is the age group, or starting at age 50, which is the current guidelines to start screening for patients who are completely asymptomatic with no symptoms whatsoever. So right now, the group which is above 50 is the group that is currently being screened for colon cancer. And as you can see, all these curve and the lines, that we've been successfully able to reduce the incidence of colon cancer in majority of these groups. However, the problem that we're starting to identify now is this curve. In patients who are younger, patients who are between 20 and 49, this curve has now started to go up in terms of incidence. And that is a new phenomena that we're starting to see, which is now re-emphasizing the need to look at earlier colon cancer screenings. So if you talk about colon cancer screening in younger individuals, if you look at the overall data, the median age of colon cancer has decreased in the United States from 72 years of age down to 66 between the years of 1990 to 2016. And part of the reason is increased screening and increased surveillance. However, the colon cancer continues to be one of the most lethal cancers that still continues to haunt the population, and is now leading to increased incidence in younger population. And partly, we think that higher incidence could be potentially related to increasing obesity and obesity epidemic, increasing rates of smoking, and more sedentary lifestyle. Some of the other contributing risk factors are increased red meat consumption, high fructose corn syrup use, overall increased antibiotic use in patients with higher incidence of inflammatory bowel disease or genetic disorders that are now coming to attention. Now, talking about where do we stand in terms of screening some of our younger adults, population that is between 20 and 49 years of age. And if you compare United States with some of the other Western countries, the incidence or the change in colorectal cancer incidence over 10 years has actually gone up compared to some of the other European countries like Austria, Italy, and Lithuania. And we see a negative trend in those countries in that younger age population compared to some of the other countries, including United States, where the cancer incidence has gone up. And we see one differentiator in that, and that is that in some of these countries, the screening starts at a much earlier age. Talking about Austria, where they start screening patients at age 40, and they've been doing that successfully since 1980s. And that definitely could be responsible to some parts of a negative or an improved outcomes related to colon cancer in younger patient population. Then the other question that naturally comes to mind is if this detection bias of having increased cancer in younger patient population, is this the detection bias? Because we know that there's increased number of endoscopies that are being performed for younger adults for various reasons. These could be diagnostic exams where patients could be having symptoms, or this could be other symptoms leading to a colonoscopy where you then eventually go and find a colon cancer. However, the answer to this question is that it's unlikely that it's a detection bias phenomena only. And the reason for that is the more cancers in younger adults that we find, we're actually finding them at a later stage and at a more advanced disease stage compared to some of the cancers that we found later on in life, which is generally earlier on and not as later stage as we see a phenomena in younger adults. So there's definitely part of the biology that is playing a role since the detection happens at a later stage. Also, younger adults have a longer duration of symptoms, but those with stage 3 or 4 had shorter duration of symptoms, which eventually led to diagnosis. So a lot of these younger patients, when they were found to have cancer, they were in an advanced stage and had duration of these symptoms for a much longer time. That sort of goes against this this theory that since we're doing more, that's why we're finding more. So there's definitely something at play, which is leading to increased colon cancer incidence in patients who are young. Now, based off some of this data, in 2018, American Cancer Society came up with a new recommendation, which was that in 2018, based on some of the studies that we just looked at, they recommended that we should start screening all asymptomatic patients at age 45. And this was a qualified recommendation, which showed that there was a clear benefit over harm in starting to do this, just because we would be able to pick more cancers in a younger disease population and then be able to deal with that. And as part of the screening process, all positive results on a non-colonoscopy screening test, which we will talk in just about a minute, should absolutely be followed up with a timely colonoscopy to confirm that there is no colon cancer that we could be dealing with. And also incorporating this epidemiological shift into contemporary modeling of colon cancer, screening demonstrated that the benefit burden benefit burden balance is improved overall by lowering the age to start screening at age 45. So American Cancer Society highly recommends starting colonoscopies at age 45 in patients who even don't even have symptoms, which could be suggestive of colon cancer. So right now, we're looking at a table that talks about what options there are available out there that are screening tests for colon cancer. There's certain stool-based tests, which is checking for blood or altered DNA in the stool. So you have a GOAC-based fecal occult blood, then you have a fecal immunochemical testing that can be done every year, and that looks for blood or concerns for bleeding in the stool. And then a lot of people might have heard or been familiar with the FIT or fecal immunochemical-based testing, looking for altered DNA along with that. And the most commonly known test in this regard is the Cologuard, which is recommended every 1 to 3 years. So there's some stool-based test that can be performed every year or every 3 years. And then there's a direct visualization test. And most commonly offered is a colonoscopy, which can be done every 10 years for patients who don't have polyps, or sooner if they're known to have polyps on their first exam. Similarly, some of the other tests that look at direct visualization of the colon include CT colonography, which is a CT scan that is reconstructed based to give through a software to give a picture of a colonoscopy exam and see if there's any polyps that could be looked at on that exam. A flexible sigmoidoscopy, which is a shorter form of a colonoscopy where you're only looking at the last part of the colon. It's recommended as a screening test every 5 years. And then also combination of flexible sigmoidoscopy with the stool-based FIT testing that could be performed every 10 years with FIT being done every year. So there's various options that could be utilized for screening patients for colon cancer. However, as majority of the GI and United States Preventive Task Force Society recommends, the first option should be to offer a colonoscopy or a FIT-based test for patients who are interested in getting screened. The problem that comes with earlier screening is that we think that it does pick up more cancers. However, does it actually mean that we're going to be diverting resources away from a high-risk population standpoint and increasing disparity in terms of care? We are starting to do colonoscopies or colon cancer screenings at age 50, but if we decrease the limit to 45, that would definitely increase a big pool of patients that would need to be starting to be screened. And how efficacious that is in terms of picking up those extra cancers versus the major population that actually gets affected by colon cancer is people who are later on in their life. Even despite the current guidelines, we're not doing a great job in terms of screening everybody who requires screening. So the National Colorectal Cancer Roundtable goal for colon cancer screening in 2018 was that we wanted to achieve a colon cancer screening in 80% of the eligible patients. However, despite having that goal around at this point, or 2018, we're still below that metric. We're only in the low 60s in screening all those patients who do require screening with the current guidelines in place. There's several high-risk populations that continue to remain under-screened, and most of them are African-American populations, recent immigrants who are not incorporated into the health system yet, patients who don't have current insurance and are not able to get in with their physicians and providers, and also those with limited financial means and access to broader health care. And of all the 60% of the patients that we're screening, majority of them are getting colonoscopies as part of their screening test, and about 26 to 27% of their patients are getting FIT testing, and about 12% are getting GOAC-based fecal occult testing. However, another point that is important is to realize is that every time you have a non-invasive test, which is a stool-based test, come back positive, it should be followed up with a more visual-based test, which is a colonoscopy. And our conversion is also subpar at this time. So the data that regards to the colonoscopy follow-up to a non-invasive stool-based test that was positive also hovers around 60%. So even if a patient who's had a positive stool-based test, converting them into getting a colonoscopy is also subpar. And then, the other ethical question is, if we reduce our age from 50 down to 40, what that would mean is that there are going to be additional about 11 to 20 million additional exams in terms of getting colonoscopy procedures. And if as a nation we're ready to absorb that kind of patient population with the current availability of gastroenterologists and endoscopy units available around the country. So if we purely look at the cost effectiveness standpoint, as we talked about, most of the cancers happen generally in the later age. So most of the cancers that we see or the cancers that we actually prevent is usually in a higher age group, 60 to 75, followed by 50 to 75. And few cancers that we pick up are actually in the younger age population. And in terms of the deaths that we can prevent by incorporating a screening program, the highest benefit is actually in terms of dollars that we spend is going to be still in a higher age group subset, and not as much in the lower age group subset. However, but we're starting to notice that this is the group that is now starting to have the highest uptrend in terms of the incidence. So there's always going to be an ethical debate about this, is that, with the limited pool of resources that we have, should we just continue to focus on the age groups where we're actually making the most dent, or we should actually try to move our cursor more towards the left and starting to screen early, where the cost benefit may not be as good, but still we need to keep an eye on this group as to, this is where the colon cancer is starting to now increase. So where do we stand right now? The current practice, majority of the GI or gastroenterology societies and United States Preventive Services Task Force recommend starting screening in average risk patient population, which is asymptomatic at age 50 years of age. American Cancer Society came up with a guideline to start screening patients at age 45. And one of the new GI societies recently came up with their recommendation, which is American College of Gastroenterology, to start screening at age 45. We do expect that United States Preventive Services Task Force would be coming up with more renewed guidelines, which are likely expected in year 2023 and 24, which would incorporate some of the data utilized by American Cancer Society, and that may then pivot the guidelines towards starting screening at age 45. However, at this time, insurance companies that provide coverage for some of these screening exams are likely to continue to dictate as to what age we start our patients based on what insurance coverage they have. However, one important point that everybody needs to remember is anybody who has any symptoms like rectal bleeding, changes of bowel habits, any new symptoms related to weight loss, new iron deficiency anemia, they really, even if they're less than 50 years of age as of right now, should be evaluated promptly with a colonoscopy exam to make sure that they don't have anything going on which could potentially be a cancer. Now, quickly talking about some of the racial disparities in colorectal cancer outcomes. As we talked about previously, colorectal cancer mortality in Blacks went from being 10% lower than those in the whites in early 70s to almost 50% higher by 2005. So this window started to get, these two graphs started to get bigger and bigger over time. And the widening racial disparity was largely driven by distant stage disease, where we were not able to pick them at an earlier stage. It did decline in whites while remaining stable in the Blacks, and that led to the curve getting bigger as this curve, as you can see that, this curve dropped pretty significantly, but then, this did not follow as quick of a trend. And similarly, the mortality did not quickly taper down compared to mortality in whites, and that led to a bigger difference in the outcomes in the two patient populations. We think that this racial disparity is in part attributed to a combination of lower screening in African Americans and also possible some genetic factors which lead to lower stage specific survivals among African Americans overall. Just a few other quick points on racial disparities. By estimation, 40% of the racial disparity in colon cancer survival is due to later stage of diagnosis, which we just talked about, and more unfavorable tumor characteristics at the time of diagnosis, and generally more comorbidities, including other illnesses among Black patients, which preclude them for more definitive therapies in terms of treatment. Also, there's national studies that highlight that the Black patients are less likely than others to receive appropriate surgery, adjuvant chemotherapy, and radiation treatments that we have known, and this could be related to multiple different factors. Also, we feel that among those who are 50 to 54 years of age, colonoscopies are more likely to be received by patients who are actually higher level of education with college graduate degree. Hispanics are generally a group that is lacking in terms of receiving colonoscopies in a timely fashion, and also uninsured patients had lower rates in all age groups. These are some of the factors that we need to work on in terms of improving adherence to colon cancer screening. Some of the new stuff that is out there, there's a new buzz about artificial intelligence technology in overall endoscopy and similarly in colonoscopy as well. What artificial intelligence is, it's actually a pattern-based technology which looks at pattern recognition, where a software is taught and self-taught in terms of looking at how a polyp could look like, how a cancer could look like, and that would aid a proceduralist or somebody performing an endoscopy to look at an area that the naked eye or a general exam could otherwise miss. And it seems to be the way artificial intelligence has helped in multiple different other areas of medicine. This probably could be a future in endoscopy in the coming days. As a matter of fact, the very first device utilizing artificial intelligence-based technology was approved by FDA in this past month, within April of 2021, and hopefully we'll be seeing a lot more centers adopting artificial intelligence in terms of their routine colonoscopies. So this is just a picture illustration of how this generally looks like. Small subtle polyps which can grow into a cancer can be easily missed during a colonoscopy exam, and this artificial intelligence based software can help prompt areas that this software picks up as potential polyps, and then the endoscopist can perform a more detailed exam and deal with those lesions. As a matter of fact, we currently at Erlanger Health System are also a lead site in an ongoing multinational clinical trial, which is ongoing in multiple different sites across the US and other European countries. And we're actively enrolling patients for this study that we're part of. So I think artificial intelligence is here to stay, and it's probably going to be a major player in multiple aspects of endoscopy that gastroenterologists practice. Now, changing gears towards fatty liver. NAFLD, which is a short form for non-alcoholic fatty liver disease, it's becoming more and more common in the United States. By different estimates, we think the prevalence of NAFLD ranges anywhere between 17% to 15% in patient population. And some of the analysis based on NHANES database from 1988 to 1984, based on ultrasound database, it shows that about 90% of the ultrasounds actually showed patients who underwent ultrasound had fatty liver disease noted on ultrasound. Some of the meta-analysis that were done between 2006 or 2014 actually showed the prevalence to be a little higher, anywhere between 20 to 29%. And we estimate that based on some of these estimates that the total number of NAFLD cases around 2015 were about 83 million, with the prevalence of about 30% in adults who are above 15 years and older. So that's a staggering number, 83 million of patients who could be having fatty liver disease. If you look at these graphs, it does talk about the incidence of decompensated cirrhosis and incidence of liver-related deaths that we project from 2015 going on to 2013. And fatty liver is going to be a major player in terms of causing cancer or liver-related death or incidence of hepatocellular carcinoma over time. And this seems to be actually starting to keep going up and up. Some of the definitions that we need to talk about, is NAFLD is where the patients have excessive fat accumulation with insulin resistance, steatosis of more than 5% in hepatocytes, and exclusion of other causes of fatty liver like alcohol-related liver disease. And then there's a differentiation between fatty liver disease, which is just steatosis with some inflammation, with NASH, which is non-alcoholic steatohepatitis, which is presence of fatty liver with some injury to the liver, which can lead to scarring and fibrosis that eventually can then lead to early scarring, then to increased scarring, and then eventually to cirrhosis, which now is also a risk factor for hepatocellular carcinoma. So this is how it looks like, if you have a healthy liver and then it starts to have some extra fat deposition. If that fat goes away, your liver can have a reversible pattern going back to a healthy liver. Similarly, this fatty liver can convert into NASH with some scarring. However, if this gets halted at this stage, it can go back to fatty liver and eventually reversible. However, once somebody goes from having a stage of NASH into cirrhosis, that's an irreversible stage with complications related to that. We think the natural history of fatty liver takes about 18 to 30 years, where a patient would just having fat on their liver, then can transform to NASH and then advanced scarring to eventual cirrhosis. However, this is where most of the problems happen as a complications of cirrhosis, which could be death or complications related to hepatocellular carcinoma in these patients. Diagnosis, this is a quick algorithm as to how these people can be diagnosed. Metabolic syndrome has to be carefully assessed in all patients with metabolic syndrome in fatty liver. Also, obesity, elevated liver enzymes, those are all triggers that actually should prompt providers to look into diagnosis of fatty liver, then eventually would require referral to specialists after some of these things have been looked into as a concern. The important thing in terms of how to manage fatty liver, the cornerstone of all this is lifestyle modification and weight loss. There's some pharmacological therapies and surgical therapies that we're going to quickly touch upon, but at the base of all this is exercise, diet, behavioral modification, and then we start to address some disease population subsets. It's a multi. It has to be dealt in a more of a comprehensive lifestyle approach fashion. Fatty liver, we're talking about energy restriction. We're talking about decreasing fructose intake, decreasing alcohol intake, increasing physical activity. Also talking about certain diet nutrients that needed to be limited or increased in terms of how to lead to decreased fat accumulation and eventually fat resorption. Right now, in terms of pharmacotherapy, there's a few insulin sensitizers that are out there that are currently being utilized. However, none of these treatments are actually approved as FDA-approved treatments for NASH or fatty liver alone. Metformin is a commonly insulin sensitizing agent that is used for diabetes, which can help. However, it's not the treatment approved as an FDA-approved treatment for fatty liver. Similarly, pioglitazone has been shown to be better in terms of fatty liver than placebo in some of the studies that have been done. Another therapy that is out there, which is vitamin E, and that also has been shown to improve outcomes in patients who are non-diabetics, and it does help with improving inflammation, steatosis, and ballooning, and resolving NASH. However, this is only approved for patients who are non-insulin diabetics. However, there are some concerns about long-term safety data that exist. In terms of surgery, bariatric surgery is a viable option in patients who are unresponsive to lifestyle changes or pharmacotherapy. It does reduce weight and then also leads to improvement in metabolic complications related to obesity. And there's good results that are out there in terms of long-term outcomes related to bariatric surgery in fatty liver disease. Fatty liver disease associated cirrhosis is one of the top 3 indications for liver transplant, even at this time and over the years to come. The last part of my talk, I don't know how much time we've got left, which is to talk about GERD, which is commonly known as gastroesophageal reflux disease. This is a huge issue in terms of patient population. Currently, we estimate 20% of the US population experience GERD. About 81 million suffer from that. About 10 million see a doctor. About 67 even receive a diagnosis, and very few actually choose to get anything more definitively done. What GERD actually is, GERD occurs when there's a valve at the very bottom part of the esophagus, and that becomes faulty. Usually this valve is closed where all the acid that is produced in the stomach after we all eat and leads to acid production stays closed, and this does not lead to acid going up. However, if this valve becomes faulty, there's more and more acid that keeps refluxing into the esophagus that leads to then symptoms of heartburn and other symptoms that go along with that. So it's actually a misnomer that reflux is caused by stomach acid. We all produce some stomach acid as long as it stays within the stomach, it's fine. But if it starts to go up, that's where the problem happens, and that's where GERD becomes more of an issue. It's a chronic issue that is related to the esophageal valve not closing properly. Most of the common things that people know of in terms of treating GERD, patients take common used medicine group called proton pump inhibitors like omeprazole, esomeprazole, but these medicines don't cure reflux. They just decrease the acid amount of stuff that is going up into the esophagus. They help manage the symptoms by suppressing the acid content, but the esophageal valve still is faulty and is not working properly and would not be helped by just using these PPI medicines. Now, available evidence suggests that long-term use of these medicines also could lead to other problems. There's data about chronic kidney disease leading to low magnesium levels, increasing incidence of C. diff infection, and concern for osteoporosis, just because there's heavy reliance on the use of PPI at this time. According to FDA, over-the-counter PPIs or these medicines are only intended to be used for about 14 days of a course at a time, and they can be used a few times a year. But now we know that there's patients who are actually there on these medicines for a very, very long time. In terms of treatment for GERD, again, lifestyle is at the cornerstone. Anti-reflux measures where you don't go to bed soon after you eat or go to bed on a full stomach. Don't take a lot of carbonation close to bedtime when people have to lay flat, which is diet modification that we always recommend. Lifestyle modification, losing weight, definitely is something that helps a lot. Some of the common medicines that are used to prevent the side effects related to chronic acid reflux, we utilize proton pump inhibitors, ACE2 blockers, things like famotidine or ranitidine are some of those medicines that have been traditionally used for that. Now, there's surgical options that are available, including hiatal hernia repair surgery or fixing the valve, which is called fundoplication. So if things don't get better with just lifestyle, then we try medicines, and if that doesn't work, then we have to get into the procedural domain where this GERD can be improved. Now we have a new technology that I want to quickly touch upon, which is the transoral incisionless fundoplication, or a TIF procedure. What this procedure does, it actually incorporates a device that is able to help fix or tighten up this valve that is at the very bottom of the whole process of GERD, where things start to go up since the valve is faulty. It's a device that goes through the oral pathway. It does not require any incisions from outside. That's why it's called incisionless. It leads to a wrap or tightness of the lower sphincter in a 270 to 300 degrees fashion. It still allows for belching and vomiting. That sometimes is a problem if it's a surgically repaired valve, where if it gets too tight, the patients are not able to belch or vomit, and that could be a significant problem or distress for a lot of these patients. It also leads to shorter recovery since it's not actual surgery. Now we have newer technologies in terms of TIF and how this can be combined with some of the surgical options. We have endoscopic therapy, which is this TIF that can be utilized to fix that valve and help with fixing the valve. We also are now looking into some combination therapies where a surgeon goes and fixes the hiatal hernia, where part of the stomach is moved up into the chest, and at the same time a gastroenterologist goes and tightens up the valve in the same session, and those both could be combined in one session and with very long-term durable results. This is some of the most recent data that talks about the outcomes related to some of these procedures, and some of the data shows that about 81% of the patients who underwent TIF are not using PPIs after they've successfully undergone a TIF procedure. Some of the inflammation that gets in the esophagus have also been shown to have great results in terms of after they get their valve repaired in terms of a TIF procedure. Also, 81% of the patients who did undergo a TIF procedure showed improvement in terms of their quality of life scores. And this data is actually a pretty durable data over 10 years in the studies that we currently have. Again, GERD is a multi-specialty or multi, or it has more of a generalized approach, which includes, patients they probably would be needing to talk to their primary care physicians, gastroenterologists, A lot of pulmonologists see patients with chronic cough that could be related to GERD. A lot of cardiologists are seeing patients with chronic chest pain, which could be related to reflux related. ENT physicians with sinusitis and laryngopharyngeal reflux do get patients with that they see, which could be related to GERD. So what we're trying to put together at Erlanger is a comprehensive reflux center where we provide comprehensive care for patients who do have or suffer from reflux disease, which include performing a full area of diagnostic testing and then offering them certain procedures, which could be including surgery or endoscopic fix for their valve. So that's all what I had to talk about so far at this time. And I'll be happy to take any questions from the audience that come to mind. And thank you so much for paying attention. Thank you, everyone, for attending the talk. I see quite a few questions. I'm going to try to take them all. I think the one common theme that a lot of people have asked is related to colon cancer screening guidelines. I have a disclaimer. When this talk was recorded, it was about a month ago. And since then, actually, as a matter of fact, about 2 days ago, United States Preventive Services Task Force came up with their final recommendations that decreased the age of colon cancer screening to 45. So it was a grade B recommendation, which is very high grade. Is now endorsing as well. So bottom line, the focus has already shifted to 45. We feel that most of the insurances will follow that recommendation because it's a grade B, high grade recommendation to start screening at age 45. So that's definitely something that we're going to be now seeing a lot of shift starting at age 45. I also alluded to this in my talk as well. Now, any test which gets done is probably the best test that could be done. So it's not about doing a colonoscopy or it's not about doing a stool test. It depends on patient dynamics and what they're able to get. We always prefer a colonoscopy test, and part of that reason is it's both a diagnostic and a therapeutic test. If you see a polyp, you can remove it at the same time. Some of the stool-based testing and some of the other non-invasive testing are largely diagnostic, which sometimes then becomes a challenge. If they're positive, then the colonoscopy becomes more of a diagnostic colonoscopy afterwards. So both of these tests, stool-based test or visual-based test, colonoscopy or stool-based test, now we're hoping that most of the insurances would approve them starting at age 45. So if you have patient interest in getting colon cancer screening, both of these tests should hopefully be covered in the coming days through their insurance companies. One other question that I saw was related to the diet. It is true. Now we do recommend more of a healthier, balanced diet, which is good portions of vegetables, fruits, and a plant-based diet. Anything that is a balanced diet is what we'd recommend. You just don't have to cut out red meat thinking that that's the only risk factor that leads to colon cancer, but that is a part of a bigger diet plan, which has to be a balanced diet overall. But definitely plant-based diets is what, or high fiber diet is what we generally recommend. Also, there was a question about the family history of colon cancer. That has always been part of the guidelines. If you have patients who have family members with colon cancer, that automatically reduces the age for when they can start getting screened, which would mean that if somebody has a family history in a first-degree relative, they should start getting screened at age 45, or actually 10 years younger to the age when that relative was diagnosed with colon cancer. So that's always been part of the guidelines, and that is not going away. If you have family history in a first-degree relative, that's a high-risk condition, and you should definitely consult your GI to see when you can start getting screening for that. Also, there was a question about if patients are not able to have family members or friends who can bring them for an invasive test, what are the options? If there's a patient-specific situation where they're not able to get an invasive test that requires sedation or anesthesia, there's other options like stool-based tests that can be performed in the office, in primary care office, or at the comfort of their homes with Cologuard, which is a kit that gets mailed to the house and then can be sent back to the company. I see some of the questions related to fatty liver. So fatty liver is not a problem till the lifestyle changes are followed until we have concerns for what we call non-alcoholic state of hepatitis, which is NASH. So NASH is mostly a concern in patients who have background of metabolic syndromes. If people have hyperlipidemia, insulin resistance, hypertension, obesity, sleep apnea, those sets up a subset of population are high risk of NASH, and that is where it starts to become irreversible, where you should definitely seek a specialist help to sort of talk about some of the strategies that can mitigate fibrosis that eventually will lead you to cirrhosis. So definitely when they have metabolic syndrome history, that is something that they should be consulting a GI or a hepatologist. Then there was a question about, are we doing a TIF or fundoplication at Erlanger? Yes, we're the only site in the whole region that is actually doing a TIF procedure. So we're very fortunate that we actually have a great partnership with our surgery colleagues that we do. We're starting to do combined hiatal hernia and TIF procedures, and people who don't have a hiatal hernia to just get a TIF procedure alone here at Erlanger. So that's definitely something that we're able to help our patients here at Erlanger. And also, I like to point, how patients can be referred for colon cancer screening. We're academic UT Erlanger academic GI. Our access number to our office is 423-778-4830. We'll be happy to definitely take care of any patients who are interested in getting colon cancer screening performed. Now, there was a question, what are the recommendations for colonoscopy if no first-degree family members have a history of colon cancer, but multiple second-degree relatives? That's another good question. That definitely also has an increased risk. It all depends on when these second or third-degree relatives had their colon cancer diagnosed in terms of age. And then we have recommendations based off how many and what age. And that's also a discussion that the patients should have with their gastroenterologist, because based on guidelines, those are different recommendations. And it's something that should definitely be addressed in a GI physician's office, depending on how high the risk is based on who actually had it in their second or third degree relatives and what age they had. So that is also an important factor to consider. So I think we're running out of time. So thank you so much for your attention, and I'll be happy to take any other questions in the chat box if need be. Thank you.